our webinar today. Welcome, everyone. For those of you just joining us, we're going to get started in just a moment. Thanks for being with us today. Well, hi, everyone. Welcome. I am Michael Morella, Managing Editor at U.S. News and World Report. In today's webinar, we're going to be examining charting a path forward for pediatric health equity. Today's session is part of our Healthcare of Tomorrow virtual event series. I encourage you to visit usnews.com/healthcareoftomorrow to learn more about today's lineup and some other events we have coming up this year. Now, I want to get right into it. For our first segment, I'm very delighted to welcome Audrey Boone-Tillman, Executive Vice President and General Counsel of Aflac, and Erica Jensen, Senior Vice President of Marketing, Donor Registry Growth and Development for the National Marrow Donor Program and Be the Match. Welcome to you both.
Thank you.
Now,
thanks for having us.
Erica, I want to start with you. Many of the clinicians and pediatric leaders in our audience are likely familiar with your organization, but could you just tell us a little bit about Be the Match and also help us understand why there is such a great need to diversify the National Marrow Donor Program?
Yes, I want to first start. Thank you, Michael, and U.S. News for bringing awareness to these important topics that are impacting thousands of patients. Every year, thousands of patients are diagnosed with blood cancers like leukemia or deadly blood diseases like sickle cell, and they look for a cure through the blood stem cell registry or a marrow transplant from a matching donor. That's where we come in at NMDP Be the Match. Only about 30% of the time will a patient find a match in their family. So that means 70% of the time you're reliant upon a complete stranger and for us to find a suitable donor for you through our registry of unrelated members that are on. And unfortunately, the important reason that we are also here today talking about health equity is that patients do not all have an equal chance of finding a match. Patients are most likely to match with a donor that shares their same ethnic background, but our current registry lacks diversity. If you are Black African American like myself, we currently have a 29% chance of finding you a match, whereas that's compared to a white patient that has a 79% chance of finding a match. So we are doing everything possible to increase awareness about this disparity and work within local communities to get people of more diverse backgrounds on the Be the Match registry so that we can save more patient lives.
Thanks, Erica. Audrey, where does Aflac come in here? What spurred your involvement with Be the Match and these kinds of life-saving treatments? And what other efforts do you have to care for young people with cancer and rare diseases?
Yes, thank you for having me. And at first, let me just say, Michael, all morning I've been thinking about the folks down in Florida who are in the eye of the hurricane and just thinking about the ordeal they're going through and what they're having to do to adjust their families and their lives. So I know all of us send our thoughts and our prayers to them in Florida. But as far as Aflac and our connection with Be the Match, this actually isn't our first time associating and partnering with Be the Match. In 2009, we were made aware that one of our sales associates had been a donor to a baby boy and had saved his life. And when we found out about that, along with some of the statistics that Erica just mentioned, we knew that our employee base and our sales force base, which is very large and very engaged and very diverse, would want to help. So we began publicizing Be the Match and having drives. And back in 2009, 5 of our Aflac team members were actually matches because of the drives that we did. So those are potentially 5 lives that we saved just because we heard about Be the Match, connected with them, and partnered. So it's our second go round formally with them, and we're really pleased to partner with them. But also Aflac, because of our support of childhood pediatric cancer and sickle cell anemia, has been in the fight to support patients with those diseases for 30 years. And the company has given over $160 million in that 30 years for those 2 causes. So when we started to look at the statistics and how difficult it is for people of color and specifically Black children to get matched, we knew we had to do something about it. Really, the only cure that there is for sickle cell is a stem cell transplant. And so to know what Be the Match was doing to try to increase those numbers, we just knew that it was a great partnership and that we had to have some collaboration with them.
Well, Erica, thinking again about our audience, how can some of the leaders at hospitals, children's hospitals or hospitals more broadly, get involved or help build awareness about the need for diversifying the pipeline of transplant donors and kind of understanding and addressing some of those statistics that you mentioned a few minutes ago?
Absolutely. We know that this audience is very involved, not only within their professional organizations, but also within the communities that they serve. So when able, if you could share the message about how we need more ethnically diverse members to join the registry, encourage people to visit us at bethematch.org, where they can learn more on the multitude of ways that they can support. We are always looking for new donors 18 to 40 that can come on board and are willing to be able to say yes to impacting a life. We have a wealth of information on our website about the process, how to support. It's easy to join. It's digital based, and we will give you all the information you need. If there is any inquiries or additional partnership, we also have a link if you want to host a drive or do something in a community organization that we are involved in. We most definitely consider the partnerships that we have with the hospital systems important in terms of helping to increase the awareness, and are always here to provide information and support on the different ways people can volunteer, advocate, they can donate money, and then of course, sign up to be a member of the Blood Stem Cell Registry.
Thanks, Erica. Now, Audrey, you started to allude to this, but just to ask the question more directly, how is Aflac partnering and working with children's hospitals to support clinicians, child life specialists, and others at those kinds of institutions?
Yeah, well, the first thing that we're doing is we're helping to get the message out. We're wanting people to be aware of the circumstances surrounding the need for bone marrow transplants and the treatment of the use of that in the treatment for pediatric cancer and for sickle cell. Last week, I just hosted an employee webinar, a town hall, to get the message out there formally to our employees about the need to do this. And we'll be doing that with our field force, and that's tens of thousands of sales associates throughout the country. So awareness and education is really important, and we're actively engaged in that. But also, we want to make sure that we're providing comfort and support to those people who are affected by those diseases. And one of the ways that we do it in particular is by providing our little My Special Aflac duck to patients of pediatric cancer and sickle cell. I mean, this little duck, it's not a stuffed duck, it's a robotic duck. And through the use of different robotic tools, it helps to comfort patients and help them to get their emotions out, their feelings out. Many times patients are so young, they can't verbalize what they're going through, but the duck helps them do that in a way that's therapeutic for them. So we're providing this little duck. It's about $200 to manufacture this duck, and we've provided over 18,000 of those ducks at no charge to children who are sickle cell patients and pediatric cancer patients. So by way of educating and helping to spread the word, and also comforting the actual patients that are being cared for in these facilities, we feel like that's a way that Aflac can and has been directly impacting those causes.
Well, Audrey and Erica, I want to, in a few minutes, we're going to hear from several clinicians about how they're working to tackle health disparities, picking up on some of the threads that you all talked about. We'll also be hearing from NBA star Marcus Smart about his own experiences with cancer in his family and health advocacy. Do you have any final words or calls to action before we move on? Erica, maybe I'll start with you.
I would encourage everyone, if you are not aware of the disparity, to go to our website at bethematch.org to learn more. It is something that we are driving behind. It is our vision to democratize cellular therapy and drive equal outcomes for all. And we know it matters. It matters to our ethnically diverse communities and patients that they have an equal chance at life. So learn more, go to the site, encourage communities that you're involved with and talk about the disparity, help drive that awareness that Audrey was talking about, and then you can take action, whether you are signing up people to be actual members of the registry, encouraging people to advocate, to volunteer, or also to financially donate to support the work that we do. There's a lot to still be done, and we're excited to have as many people as possible join us on this journey.
Echo and support everything that Erica has said. I mean, that's excellent advice, but I would also give a specific call out to the African-American community. There's just no reason why the donor should be that small, and the likelihood for matches should be that significantly different. But it's education, it's awareness. I'll tell you, several years ago, probably 25 years ago, when I was a new lawyer in practice, I got on the donor registry because the Bar Association was looking for a match for a young African-American woman who was dying and ultimately did die from leukemia. I knew nothing about it. I knew somebody had to tell me and educate me. So we need to do more of that, and specifically in the African-American community, to get these numbers up and give these patients more of a chance.
Well, I want to thank you both so much, Audrey Boone-Tillman and Erica Jensen, for your insights, for the work that you're doing, and for your support. I think there's a lot we can learn from that, and I'm excited to explore the issue further.
Thank you so much.
Thank you. We appreciate this time. And Audrey, we appreciate Aflac and your partnership.
Thank you so much. We're glad to be here.
Well, you heard me mention it a moment ago, but before we introduce our panel, we would like to share a special interview with Marcus Smart, Boston Celtics guard and the NBA's reigning Defensive Player of the Year, about his family's battles with cancer and what drives his personal advocacy for achieving health equity. Let's take a look.
I'll probably say my journey and my family's journey that we've been on and went through has shaped, I guess, my perspective in the way that, trying to educate myself more about, a lot of these healthcare crises that not only I went through, but that I know other people around the world are going through. And it's not easy. The journey is definitely something that, nobody's ever prepared for. And you have to get ready and prepare. But although, I lost both of my mom and my brother, it wasn't in vain. They taught me a valuable lesson, and, life's too short, and live it to the fullest. But it also allowed me to stop my everyday life, because as individuals, as humans, we kind of get caught up in our own lives sometimes, that we forget that there's other things in life that need more of your attention sometimes. And for me, my journey with my family is that for me, it was the stopping point for me to sit down and say, hey, there's other things more important than life, than this or that. And these are some of the things, and to be able to help someone who has went through something similar, is going through it, or has no idea what to even expect, to be able to share the light and educate that I know and the wisdom that I know and been through with them, makes me doing this and partner with Aflac and Be the Match even that much better. Definitely, giving back is something, I was always taught. That's who my mom was. She was always giving, even if she didn't have anything. So giving back was just in me, but to be able to give back to something of this stature, like I'm doing with Aflac and Be the Match. My parents, like I said, my mom and the loss of my brother, it was tough for me because I had to go straight back to work afterwards. So for me, it was like, you know what? How can I change the game in the way that I know how? Well, for me, that was exactly what I'm doing here with Aflac and Be the Match, being able to bring awareness to something that hits so home with me, and to see that, dang, a lot of people look up to me knowing who I am as a professional basketball player, and then they realize he's just like me. He goes through problems just like I do. just like any other human being. So for me to be able to give back, it means more than literally giving back. It means more than anything for me, because I would want somebody to do that for me if I was in that situation and needed that. And also, I understand what it feels like to not have the support or to have that give back for you. So that's part of the reasons why I want to give back, and being able to do that with Aflac and be the match has helped me. You'd be surprised, like having options for someone who needs options is big. So it's more than critical for us to be able to get the matches in, to be able to get donors to sign up and register to the registry, to be able to really bring even more awareness, because like I said, this is the only way that it's going to save somebody who's dealing with this life. It's the only way is a transplant. So for them to be able to have options, to be able to say, you know what, we may have found a donor, we're working on it, we have something. That right there in itself brings a lot of hope and just a bigger smile and a sense of like, man, you know, everything it's going to be okay. It's bad, but it could be worse. And I'm okay right now. You know what I'm saying? Sometimes they're kids. You got to understand, a lot of times it's a lot of kids that are going through this, adults as well. But, you know, so just imagine as an adult hears something about like, hey, you're diagnosed with this. Imagine the kid, you know what I'm saying? So it's more than crucial for us to diversify, to be able to bring awareness, to share light, to get donors in, especially in the African-American communities. I think the numbers is 29% to 79% when it comes to being able to find that match. So, you know, that shouldn't be it. You know, we should be able to have a match. And I think the only way to do that is to get people educated and get them thinking and able to do something like joining the registry to make a difference. I think my message would probably be like to say, get out, do not be stuck in your ways, you know, open your mind. And if you just can't understand it, or you don't feel like you want to, or you just don't have that same energy or enthusiasm to go out there and learn, put yourself in their shoes. Imagine if it was you or a kid or your brother or your mother that was in that situation. And I think that right there, by taking ourselves out of our own bodies and putting it in the bodies of people who are going through exactly what we're asking you to just look at this. You know, I think it'll allow more people to come forward, to not only become educated, but say, you know what, I want to change. I want to help be the change. And how can I do that? I probably have to say, just be more engaged. You know what I'm saying? Like, I think that's really coming from the African American community, is be more engaged. I mean, it's tough. We don't, a lot of times coming from low income communities, we don't have the same amount of technology, same amount of resource and approach that somebody else and our peers may have. So just being aware that you know, that we might not have the same income as somebody over here who can afford it, but that doesn't mean that my life doesn't deserve a chance because of that. And just understand that to be able to understand that everybody deserves a chance to have a chance to find a cure. And I think that's the advice I would give. And I also want to say to those physicians and everybody, thank you. I mean, you guys take a lot out of your time, out of your day, from your lives, from your family, to help others. So thank you, and we really appreciate it.
Well, as we continue to explore the theme of health equity, I'm really pleased to introduce our next panel of clinical experts and physician leaders to help us dig deeper into this topic. You can see them on your screen now. Please join me in welcoming Dr. Douglas Graham, Chief of the Aflac Cancer and Blood Disorders Center of Children's Healthcare of Atlanta, Dr. Anu Partak, Medical Director of Health Equity at Cook Children's Healthcare System in Texas, and Dr. Snehal Shah, who holds several roles at Boston Children's Hospital and Harvard Medical School, including as a primary care pediatrician with the BCH Primary Care Center and research scholar in the Sandra L. Fenwick Institute for Pediatric Health Equity and Inclusion. Welcome to you all. Thanks so much for making the time for us. Now over to Morgan Felchner, Executive Editor for News and Events at US News, to lead the panel discussion. Morgan?
Thanks, Michael. We've already heard a lot about health equity and the need to build toward it, but let's expand upon the issue from a broader clinical perspective. First, could each of you talk about your role and your respective institutions and how health equity is part of your and your colleagues' work? Dr. Partap, would you like to start?
Sure. First, I appreciate US News having this topic and this panel. I'm still learned a lot this morning already from our previous speakers. And like we opened with, I think all of us are thinking about Florida too, just to see the images and know that our topic today is really relevant to what's happening in Florida and with sickle cell and with cancer treatments and registries. For Cook Children's, my role has been about 2 years old. I'm the Physician Director of Health Equity Integration, and that title is purposeful and intent because we realize it can't be a small team in any health system that are helping, in our case, 8,000 plus employees be what we call health equity minded. So our approach has been to find many opportunities and many like-minded folks to begin championing. How do you add in health equity analytics into your data? How do you think about health equity in your operations? If we had a similar situation to Florida with a hurricane, how do you make sure any of your care delivery for those victims or families, survivors, reach every single demographic family that is affected at the same level? And it's really challenging our analytics and thinking about how we plan, implement our processes, and then measure our outcomes for equitable care. And so that's been the focus for us. And we launched that through quality and safety, which has also been an interesting, effective way for us to do that at Cook Children's.
Thank you. Dr. Graham?
Yeah, thanks for inviting me to join the panel today. So I'm the chief of the Aflac Cancer and Blood Disorder Center in Emory University in Atlanta. And as such, I'm the clinical and the research physician leader for our faculty. So in that role, we certainly have to try to figure out how we can improve upon some of the health inequities that occur both in the pediatric cancer as well as the hematology patient populations. So for example, there are some cancers in which we know the outcomes are different between Black children, for example, in neuroblastoma and acute myeloid leukemia, for example, and the white children that are the counterparts. And some of those, as we dive into that, there needs to be research into potential biological differences and responses to treatment, but also to understand the social determinants that can impact health outcome as well. Participation in clinical trial and access to drugs, whether or not the cost of drugs may be prohibitive for some of the patients to be able to be involved and get access to them, and transportation issues as well. And then with regard to hematology, our program has 2,000 sickle cell patients that we care for in the city of Atlanta and the surrounding community. Some of the same issues regarding transportation and access to care are critical to improve the quality of care that we're having for those patients. But also with sickle cell, we're on the horizon of some really new exciting therapies. And how do we make sure that we're able to distribute the quality of the new therapeutics that are just around the corner to our patients that with regard to the price of those drugs?
Thank you. Dr. Shah?
Thank you again for inviting me to this panel. I'm really looking forward to the discussion. As was mentioned, I wear a couple of hats at Boston Children's. I am a primary care pediatrician, and there's a common theme that sort of runs through all of my work, and it's this idea of sort of promoting health equity through action on social determinants. And in my work, I feel like we're really focusing on practical approaches and sort of how to actually do this work. In my role as a primary care pediatrician, I work at the hospital-based practice, and I've been working with a team to sort of strengthen how we respond to when a family presents with a health-related social need. So whether that's housing insecurity, housing instability, food insecurity. We've also actually in the primary care practice been examining how our policies and the way we do things through an equity framework. I'm also the Associate Medical Director for Community Integration in our Department of Accountable Care and Clinical Integration. And most of my work there focuses with working with our Medicaid Accountable Care organization. And in this role, I've also been focused on responding to health-related social needs, but really through community partnerships and coordinated care. Through my role in the as a senior faculty advisor in the Office of Health Equity, I've been working on sort of internal hospital-based initiatives to promote health equity. And then as a research scholar in the Sandra L. Fenwick Institute, I am, in addition to other things, my research has really focused on sort of missed care opportunities. And I think that in all of this, we're really trying to understand the drivers of health inequities to really inform the work that we do.
Thank you all so much for joining us today. I think it's going to be a great discussion. Let's start first with what has been the giant elephant in the room for the last 3 years, the pandemic, and let's reflect a little bit on what we've learned. The COVID-19 pandemic has obviously taken enormous tolls in the United States and overseas, particularly among many underserved communities and people of color. In many ways, the situation of the last 2.5 years has spotlighted and perhaps even made worse some of the deep inequities that still persist in our nation. When it comes to healthcare in the US, can you share any specific examples of solutions or promising practices to move toward children's health equity that may have come out of the pandemic? Dr. Shah, would you like to start?
Yeah, I'm glad to start. I think it's such an important question because it's a missed opportunity if we don't learn from what's happened. And I think there are many things that happen. One thing I'd focus on is that the pandemic really shed light on the experience of families. We saw how they cared for one another and worked together through some really difficult situations and the struggles that they faced. And these struggles included social, economic, and environmental challenges and needs. Again, I mentioned food insecurity, energy insecurity, all of which we know affect the health of children. And while all of these needs existed before the pandemic, as you mentioned, the economic situation of many families worsened during the pandemic. And I think it's this increase in social needs during the pandemic that contributed to what I see as sort of an expansioning or deepening of the role that healthcare plays in addressing social needs. I think pre-pandemic, some healthcare institutions like our own at Boston Children's, we were screening for social needs and supporting families who identified a need for more than a decade. But with the increase in social needs, more healthcare institutions focused on what they can do when a family presents with a specific need. Healthcare institutions sort of figured out how to deliver food to patients, how to connect them to resources to pay their rent and utilities, and partnered with local government and community-based agencies. And I think that more healthcare institutions played a role in addressing the needs during the pandemic and really hope that it will continue.
Dr. Partap, have you seen anything at your organization or in your communities that has helped during the pandemic or and after?
I agree with everything Dr. Shah said. My background is in primary care as well. And I think what happened in the pandemic was there was a shared suffering that had been limited to a certain community before. Mm-hmm. And so the way the resilience certain communities had needed to get through the day for decades or, longer, now everyone was sort of dealing with food insecurity, or am I going to pay my rent or my mortgage, or am I going to lose my job? So from a healthcare perspective, it also meant that pediatricians and specialists who may have seen their population as being fairly well functioning were all faced with the same questions, and not just as a provider, but as a person, right? Lots of people have kids at home, their own families struggled with COVID. And I hope and think what I saw here, I hope it happens nationally, which is more of a shared compassion, understanding of what it's like to live with a lot of uncertainty and suffering. And I think the risk would be to forget what that felt like, because I think it drives the healthcare improvements that we are still needing to do. So what we did well the first couple of years of the pandemic, I think here in our town, was folks who had worked sort of together really worked well together. Right now we needed to partner in a quick way to get those resources Dr. Shaw talked about to families who'd never asked for help before too, right? And now the challenge is to not start to sit back a little bit or get comfortable because it's over, right? The pandemic is over. I had it last week. I'm not so sure COVID is that over, but and I think what we have to figure out now is how do we take the great learning and humble learning that many of us had, see how families have lived with dignity for decades, and now continue to do our humble role in expanding the way we support preventably families from running into problems. How do we support them early on without needing to wait till there's a crisis or till we wait for them to come in and say, hey, I need help. And so I think we're still on that journey as a country, but I think we're learning a lot more about how to do that better locally.
Dr. Graham, any thoughts?
Yeah, well, I agree with the previous two panelists, particularly around the need to expand the psychosocial care that we provide. We also have had a highlight around the need to address transportation issues and getting access to care. And we've been able to successfully overcome this a little bit through the use of telemedicine, which kind of blossomed during the COVID pandemic. How do we continue that? How do we make sure that insurance is going to support that? And how can our providers continue to have that level of care? How do we address some of the challenges that that we saw with telemedicine? But also we're realizing that in some of the cases, we need to deliver the care better where the patients are. And so outreach clinics, for example, we have an outreach clinic that our center now does in Columbus, where we go and provide care locally to sickle cell patients that are in the Columbus community, instead of expecting all of them to be able to drive to Atlanta to the Children's Hospital. I think that another thing that has been highlighted is the disparity in research that goes to certain diseases such as sickle cell and in research dollars that are present. And I think the pandemic helped underscore the disparity that's there. I mean, if you look at the amount of research dollars that are spent, for example, in cystic fibrosis compared to sickle cell research, it's about a tenfold difference in the dollars that are spent. And so having people come together and understand that disparity and have a commitment to invest in sickle cell clinical and basic science research is something that I'm seeing beginning to happen more. So we had a coalition of Emory and Children's Healthcare of Atlanta and the Morehouse School of Medicine, which is also Atlanta, and the Georgia Research Alliance, which is a nonprofit organization in Georgia, invested $15 million to hire 4 new sickle cell researchers, 2 clinical researchers and 2 basic science researchers. So we're seeing some positive changes, I think, and I think the pandemic helped highlight some of the opportunities.
Dr. Graham, let's continue on that thread a little bit. You mentioned sickle cell, but what about childhood cancer? How has the pandemic impacted treatment there, especially from an equity perspective?
Yeah, I think that one of the things, so childhood cancer, at least in our hospital, the admissions continue to be sky high. So they didn't slow down during the COVID pandemic, but there still remains challenges. And I mentioned the disparities that are present in some of the outcomes in childhood cancer, both for Black children as well as Hispanics. So Hispanics also have lower outcomes that we see in leukemia and lymphomas, for example. So how do we make sure that our clinical trials are enrolling a diverse population of patients, and that has been a shortcoming for many of our clinical trials, is that we don't have the representation of minority patients in the enrollment of the trial. So how do we encourage and facilitate that? Some of it may be in addition to having academic trials, having pharma trials realize that in some cases, the trials that are being sponsored might not be in institutions that are minority serving institutions. So having a diversity in catchment area for the trials, but also lowering the barriers for patients to be involved in trials in terms of providing transportation, language barriers, family costs and childcare and other things sometimes are barriers to having enrollment on trials. So finding ways that we can address reimbursement or facilitate the ability for children to be involved in trials is going to be critical. And then again, as I just mentioned, the investment in research, understanding differences that might be related to cancer biology, but also research around clinical research and understanding the social determinants that affect and impact outcome and how can we address those. So I think that we've seen that highlighted and underscored in the pandemic, and I think we're making some positive changes in that direction.
And what about mental health? So clinicians were concerned even before the pandemic that reports of mental and behavioral challenges were rising. And many say now they've reached crisis levels. There's anecdotal stories of parents trying and failing to get into a psychiatrist or a therapist for young children. Dr. Shaw, any thoughts here?
Yeah, I mean, I think that that is the ability to access mental health has been extremely difficult prior to the pandemic and was exacerbated during the pandemic. So, and I think that it's a confluence of factors around, having the workforce that's available, having payers that will pay for access to services. I think there are a couple of strategies that I think that are out there and being explored. The first one being sort of no wrong door, right? So as a child, you may access mental health services through your, let's say, primary care pediatrician, perhaps also through school, also through sort of any community agencies that you might be involved with. So I think we've definitely seen a worsening of the mental health crisis among children, and we really need to think about some of the sort of more promising practices that are out there in order to support children and families who are experiencing this crisis.
Dr. Partop, how can healthcare providers work toward promoting mental well-being, especially among underserved individuals and communities?
That's a great question. I don't think it's different for different families. I think what's different is the messaging. And so, I think that's a common theme actually when I think about what Doug was saying, and it applies to mental health. So whether you're trying to reach families for sickle cell or for cancer research, for social determinants of health disclosures, for primary care or for mental health, what happens, I think, in our busyness in child health care is we have sort of messages we just hope reach everybody, right? That it's going to resonate no matter what your life has been, what your culture is, what your language is, what your beliefs are. Whether you've had 10 doors shut on you and you've tried over and over and never managed to have somebody help your child, that we somehow think our message will still reach everyone the same. When we talk to communities and let our families tell us, what message do we need to provide for you to know we're here to help? I think that's when we start to really help families meet their children's social emotional needs. Help families trust us that you can come to us, and we may not know exactly what to do that minute, but we care about you, instill some hope, and then continue to stay engaged. And I think we're still working on getting those messages right, because we may not be where we need to be from what Audrey and Erica and we heard earlier, which is we need to involve the communities we're trying to help. It's that whole concept of nothing for us without us. And if we can master that as these big children's health institutions, we'll so successfully have families come to us, trust us, help us do better, tell us what we need to do differently next time so we can be even better. And we do that for everyone equitably then. I think one of the reasons, and I'll end just with this thought, is the mental health crisis during the pandemic was absolutely predictable the moment the pandemic was declared, because children only do as well as their families are doing. And so even now, when we think about how do we serve all these children who are having suicidal ideation, serious depression, anxiety, is how do we help their families in their home environments through the different social determinants so they can address their child's needs in partnership with us.
We've talked a little bit about it, but let's talk a little bit more about community-based partnerships. So across healthcare providers, schools, businesses, government, advocacy groups, and so forth, and the role they play in addressing equity for young people. Dr. Shaw, could you start with a little bit of perspective from your own work at the intersection of this arena?
Yeah, I think it's important first to think about sort of the child's health ecosystem as we try to think about it, right? So an individual child's health is affected by many things: that individual's strengths and the adversity they face, the family that's around them, their community, as well as those social, economic, and environmental factors, right? So we have this frame of the different things that can influence a child's health. I'll add to that there's also a sort of at a macro level, systems, processes, policies, all that determine the distribution of resources to help keep kids healthy. And again, part of that is that these systems, policies, and processes are actually underlying structural drivers of systemic racism and privilege that we have that really makes it, that really presents a barrier to pediatric health equity. And I think that when we think about addressing these inequities, we have to actually consider the range of factors that feed into inequities. And so I think that we know that most of what influences health in children sort of occurs outside the healthcare system, right? So it stands to reason that in our work, it's really important for healthcare institutions to collaborate and have partnerships with other sectors. So, you mentioned community-based organizations, schools, religious institutions, other entities that also play a very active role in the life of a child and their family. Community-based partnerships, one of the ways that we have been working on community-based partnerships is actually working with organizations to help address some of the specific social needs that a family might have. So in general, right, healthcare institutions are not housing experts, right? This is not the thing that we know the most about. And granted, there are some staff and some healthcare institutions who have a deep knowledge of housing systems, but it's in general, it's probably better for a family to be served by a community-based organization who can more fully address their range of needs. And I think that it's in this engagement with community-based organizations, there is the opportunity to support families. There's also the opportunity for us to learn from one another. Community-based organizations have also played actually a role in some advocacy efforts that we've done specifically around housing and food security in Boston. I also just want to reflect on something Dr. Pratap said about community is not just, sort of community-based organizations and other agencies in our surrounding community, but it is the people that we serve. And we really have to identify ways that for the voice of our patients and families to inform our work. And not just, it has to be sort of commitment to routinely obtaining patient and family feedback and have that feedback really inform our actions. So to really think of community in that very broad sense, I think is really important.
Let's turn towards some of the social determinants of health, which all of you have mentioned already. Given how complex the challenge is, can we drill down into some of the specific social determinants of health and how addressing those might move the needle on children's health equity? Maybe let's start with child poverty. Recently, the U.S. Census Bureau released data that showed a notable decline in child poverty since 2020, following some of the measures put into place during earlier parts of the pandemic. What can or should clinicians and healthcare leaders learn from this to move forward? Dr. Graham, would you like to start?
Well, we have to be able to address the whole patient when we're caring for the patient for any type of hematological or cancer disorder, as well as realize this is a family engagement that we're having. And so it goes well beyond just treating the disease. As I mentioned earlier, for many of our patients, getting access to the best care involves having the dollars to get to the center or have the doctors go to them. It's making sure that the families who have to actively be involved in the cancer care have a way that they're with the patient in the hospital, but they take care of the child care needs of the family that's at home. I mean, when a child is involved in a chronic disease, either sickle cell or cancer, it disrupts the entire family in terms of the income that they're bringing in and their ability to care for the other children that are at home. And unless you can address that, you're not going to get the successful care that you need for that patient. So we need to have ways that we're providing these psychosocial services. We're understanding the economic backdrop of every family. We're plugging in the gaps as we need to be able to allow them to get the access they need. The other thing, though, that I'll say is that many of these life-saving drugs and treatments now are astronomically high. When we think, for example, and I'll use sickle cell disease as an example, we've made tremendous progress in the treatment of sickle cell disease with new treatments that are right around the corner. Historically, we have used antibiotics and blood transfusions and pain medications, but now we're having drugs that are getting right at why the patient is having problems with the sickle cell disease. So we have bone marrow transplant. That's a cure that could be hundreds of thousands of dollars or more. And we have gene therapy now that can go in and potentially correct the defect that's occurring in some of those trials. And we've treated patients in Atlanta with gene therapy, but those could be $1 to $2 million per patient. So how do you ensure that these life-saving therapies are going to be available to everyone across the board in an equitable fashion? So I think when you think about poverty, you think about not only the basic care, but how do they get access to these life-saving therapies as well?
Dr. Shaw, would you like to weigh in?
Yes, I think just sort of from the bigger picture perspective, when I think about addressing social determinants, I think of sort of a three-pronged approach that healthcare institutions could consider. The first is how to work with individual patients and families. The second is how to work with communities. And the third is actually working on systems and policies, right? So healthcare entities could actually work in each one of those spaces. And I'll give a brief example. So for instance, for individuals and families in a clinical setting, if they come in with an acute social need, such as food insecurities, in our clinical setting, we can direct them to food resources, provide them with grocery store gift cards, help them access SNAP. And these are all things we actually do in our setting. And that actually helps the individual family with an acute need. Then there's the opportunity for institutions to work within our communities, right? And so, for example, we might partner with a local grocery store to help make sure there's increased access to healthy foods and affordable foods. And there's also the role an anchor institution can play in its community, right? So this is where you then have the opportunity to support not just the families that you care for, but the broader community, and to help ensure that they have access to things to keep them healthy. And then the last piece of that is that healthcare can work on systems and policies, supporting policies that promote food access as a way. And I think that if you think as an institution, what level are you going to direct your energy? Are you going to work specifically with families? Are you going to work in the community? Are you going to work on systems and policies? It's an important decision to make as an entity because your resources are limited. And I think it has to be intentional. The work has to be intentional in that way. And I think the decline in child poverty is actually something that's tied to all of this, in the sense that, right, so we know child poverty has been associated with lots of adverse outcomes in children, and poverty is intergenerational, right? So reducing poverty is actually a method of prevention, right? This is what we do in pediatrics. We try to prevent, and you could, by reducing child poverty, you can prevent current and future exposures to adversity and to poor health. And when you look at sort of the reasoning for the decline in child poverty, one contributing factor were federal and state policies that increased resources and benefits through such programs as SNAP, which is formerly known as food stamps, the child tax credit, the earned income tax credit. And so this is an example of where individual providers and healthcare institutions can advocate for these policies and funding to increase some of the social supports, not just to individual families, but to the population as a whole. And healthcare institutions can advocate, we can advocate for healthcare policies, but these are opportunities to advocate for policies and programs that affect health. And I think that there was a lot of advocacy by healthcare institutions for SNAP, Early Earned Income Tax Credit, Child Tax Credit, including our own through our Office of Government Relations. And I think it's an important example of the ways in which institutions can engage in social determinants.
You've segued quite nicely to a question that I had on my list, so I'm going to jump down there. In previous U.S. News webinars and reports, we've had experts champion the idea that health equity should be taken as seriously among health providers as something like patient safety, and that there need to be better ways of measuring and tracking progress in this area. What do you make of that, and how do you measure it? And can you point to any examples of efforts that are moving the industry in this direction? And Dr. Partak, would you like to start?
Sure. Even the conversation around poverty is an example of measuring health equity. So when we think about health equity, it is safety. It is quality care. There isn't safe quality care if it's not equitably delivered and received and experienced by every single child who comes into our institutions. So that when they arrive, they're trusting us, and we count them as a person, and we count everyone like it's the same unit. When we start to really think about demographics, we can appreciate that when we measure our access, process, or outcomes, which is the framework we're using at Cook, that each family has various demographics that influence their opportunity for equitable care. And what we often think of disparities is really discrimination, right? It's an uncomfortable term, but we need to really think about social determinants of health are determinants because people have been kept from, or opportunities have not been equitably distributed because we don't think everyone has the same value. That's a really tough sentence to say out loud, but the way healthcare institutions will do an improved job measuring and then move all of our systems forward is if we can really think about race, ethnicity, age, address, language, income, sex, whether it's gender identity, sexual orientation, or legal or birth sex, that these are all identities that we place value on that changes someone's experience when they come to us for help and when we deliver our care. And the more that we can better define the experience through identities, the better our data will be for us to continue improving and collecting and keeping us honest and accountable, I think, across the country. And it's not easy, but it's necessary for safe and equitable care and for high quality care.
In addition to tracking and measuring this, there has to be some policies and some advocacy that could be done here. And a lot of work has happened on the policy front in recent years when it comes to health equity. But can you point to any specific successes on the local, state, or national levels? And then also, let's think about what else needs to be done. Dr. Shah, would you like to start?
Sure. I mean, I think I already mentioned, right, this advocacy for social support programs and is a really important space where healthcare institutions can play a role. And I think that I mentioned the Earned Income Tax Credit, the Child Tax Credit. I think that having these supports for families really promotes the economic stability for families, which then we know is connected to almost every social determinant of health, right? Like, whether you're talking about housing, transportation, food, I think having policies that actually will affect the economic stability of families is really, really important. If I could just go back to one thing Dr. Pratap said, because I think it is such an important thing. And the idea that there is it's really important for us to sort of say out loud, right, that The inequities that we are talking about have historical and current day roots in structural racism and other forms of discrimination, at sort of the macro level in culture and society, but also in our individual institutions. And it's really important for us to think about that as we think about the strategies we're going to use to address health inequities in our institutions.
Let's go ahead and take a question from the audience. One of our attendees asks, can you share any specific examples of payers incentivizing health equity for pediatric healthcare providers? And anyone can feel free to jump in.
I have one for that. I have a response for that. So in Massachusetts, our state Medicaid program has, in working with ACOs, they've actually allowed us to use healthcare dollars to support families who are food insecure or housing unstable, right? So they'll come to our clinical setting. We learn that they are food insecure or housing unstable, and then we have resources to offer those families to help reduce the burden and the impact of these conditions. So this is, again, it's driven by our state Medicaid program, and then each ACO determines how they will actually implement the work. And it's we're the only pediatric only ACO in the state of Massachusetts, and our approach to this work has really been sort of centered on the family, right? And I think we all know in pediatrics, right, nothing happens without working with the family, and we must. And so this idea of addressing a social need really has to include the family unit, which has been work that we've been doing as we address these needs. I'll give you a very specific example around housing. So we've used these dollars to partner with a community agency, and when families are presenting with specific housing conditions, we now have a resource that is not just our own internal team, but an external resource where families can work with a community-based partner to actually try to improve not only their housing situation, but thinking longer term about economic stability for them. And so I think a lot of credit goes to our state Medicaid program for sort of allowing us the opportunity to understand the impact of healthcare dollars being used to very concretely support social needs.
In our final few minutes, I want to give each of you a chance to sort of give final thoughts, anything that we didn't get to talk about. Dr. Graham, would you like to start?
Well, thank you, Morgan. I want to express my gratitude for having this conversation today. It's such an important conversation, and be able to not only talk about the issues, but also to be able to think about what are some solutions. But as we think about health inequities in the United States, I think we also, as healthcare providers in the United States, need to think globally as well. In particular, if you look at sickle cell disease, so we have 100,000 people in the United States that have sickle cell disease, and we've been able to move the needle to where 30 or so years ago, many of those patients would not live beyond their 20s and into their 30s, and now they're living into their 40s and 50s. We need to continue to have advances there. But if we look outside of the United States, in Africa, for example, 300,000 plus children are born every year with sickle cell disease, and most of those, the vast majority of those, will never make it to be 20 years old. So I think as we're thinking about health inequities within the United States, we also need to think about how can we contribute to a better health worldwide as well.
Thank you, Dr. Graham. Dr. Partap, would you like to go next?
Sure, that's a very sobering fact too, Doug. Thanks for sharing that. Federal and state policies will come and go, and the thing that can stay steady is that children's health systems are a barometer of communities. So all day long, we're doing needs assessments, and the better job that we can do for families to trust us, stay engaged, be mindful that people have identities that shape how they experience and return for care to achieve an equitable outcome. While that's all happening, we have a great position to share data with those in charge of extra resources, care coordination, community supports, so that it feeds back to the patients that are coming back to see us again. And that continuous, really, it's a QI loop, right? That we are well positioned to take advantage of in pediatrics, regardless of what other policies wrap around our ability to take care of families.
Thank you. Dr. Shaw?
I am going to agree completely with what Dr. Partop said. I think the things I would point to, just to reiterate, right, the family voice is really important in everything. And I think that right now, there are opportunities at family advisory boards or community advisory boards where there are opportunities to sort of provide feedback, but I think that there's a need, just like we have in quantitative data, a way to continuously collect qualitative data from our families and inform the work that we do. I also the last thought would be that I think as healthcare institutions think about their work in this space, there has to be an important intentionality that this is the way we view health inequities, and we are then going to act in this way to address health inequities. Because I think that if it feels that level of sort of coordination and conceptualizing to action really can ensure that you're addressing some of the drivers of health inequities, pediatric health inequities in your populations that you serve.
That's all the time we have for today. Thank you so much to the panelists and the audience for joining us for this important conversation. To learn more about health equity in America, check out our coverage at usnews.com or tune into another webinar at usnews.com/events. Goodbye for now.